Hey mental workers, welcome back to Mental Work. Treatment planning is one of the core skills of being a psychologist, and it's something that you should have been taught at uni or through supervision. But what if your support in this area hasn't been so adequate and you have no idea where to start with treatment planning? This is what this episode is for. Today, I am sharing the microphone with Amanda Moses. She runs her own business called Amanda Moses Psychology, and she offers training and supervision to early career psychologists. So she is perfect for this podcast. And we're very delighted to have you here with us, Amanda.
I'm delighted to be here. Thanks for having me.
No worries. It's so lovely. And so we'll disclose to listeners straight up that I'm especially grateful for Amanda today because I have tried to record this episode in the past. And when I listened back to it, it was so complex. I just really got in the rabbit hole of treatment planning. And when I listened back to it, I was like, this will make sense to no one. Not even I know what's happening here. So I'm very glad that Amanda can hopefully help us reduce down some of the complexity in a way that listeners can actually benefit from.
Thanks, Bronwyn.
So Amanda, in this episode, we're going to unpack why we have treatment plans. And we're going to go through how to create a fictional one using a hypothetical case study. And we're also going to answer some common treatment planning questions along the way. Are you ready to dive in?
I'm ready.
Let's start then with, why do we even have treatment plans? Like, why don't we just wing therapy and go for it? We just get in there and we're like, okay, today we're just going to have a good old chat.
Well, I've got a few things to say to that. So I think firstly, we would be thinking that it's really beneficial for us to have treatment plans. It gives us that structure to therapy. It's our roadmap for what we need to do to help our clients, meet their objectives. But also you want to think about the things from like an ethical standpoint. Having a treatment plan in place also demonstrates that we are working within our skill set, we are working competently, and we are working using best practice. It also means that, of course, if something were to happen to us or we would need to hand that file over, somebody else could pick it up, another psychologist, look at that treatment plan and know where we're at and know where they should keep going.
So there's many benefits to having a treatment plan. It's a roadmap for how we're going to proceed with the clients. It's also part of ethical practice. Like clients are entitled to have the greatest opportunity to achieve their therapy goals, right?
Absolutely, that's right. And I think that's what it's about. It's really making sure that we're reviewing best practice, putting some sort of a structure in place and, hopefully following that through.
Yeah. Are there any downsides to having treatment plans? This just came up. I figure I'll just ask. I don't know if there's any.
I think the only danger with treatment plans is when we perhaps overplan. Right? And so I think it's like you need to have this nice balance between having a thorough enough plan that you can, structure therapy and meet those goals for therapy. But also you don't want to overplan because then it doesn't allow for that nice, the spontaneity that will occur in a therapeutic session. So what I find is that for people that are chronic overplanners, and I myself have fallen into this trap, particularly when I was early on in my career, you're managing so many different things like, that sense of anxiety, those feelings of incompetence. You're, of course, still just learning the ropes. So naturally, you're going to be doing more, reading more, planning more than you would when you're later in your career. But I think that we can fall into the trap of over-planning, which then means that we don't allow, for us to go any deeper with our clients in therapy. And what I mean by that is if I have planned, kind of step by step what I'm going to be talking about today with my client, I may miss those crucial turning points in a session where perhaps we would have uncovered some other issue that could be quite critical for that client, or something else that perhaps might be quite important for that client that they want to work on. Perhaps I've been too focused on my own agenda. And so I feel like having some sort of a plan is very important, but we don't want to overplan. We want to allow some room for flexibility and for our clients to be able to, I suppose, have some spontaneity within the session too.
Yeah, if we overplan, let's say that in the first session you have a client and you're like, okay, great, depression, and then you base your treatment plan off of that. And then in session 2, you discover that they also have panic disorder. Do you just say to the client, sorry, this ruins my treatment plan, we're just going to go with the depression?
Yeah, exactly. Yeah. And so I think that's the thing, right? It's like we fall into that danger perhaps of almost tunnel vision.
Yeah.
And then not being able to see outside of our plan and maybe what else is going on that could be, influencing or affecting our clients. So it's trying to find that nice balance.
Client would just be like, oh, yeah, okay, I guess I don't have panic disorder. I'll just keep the one under the rug here.
Yeah.
Yeah. What would you say, Amanda, to those people who are like, I practice Rogerian relational therapy. I don't need a treatment plan?
Well, I suppose as someone who's very structured and somebody who needs a plan for everything, I would struggle with that. And I think, look, again, it's having a plan in place probably is also about keeping us accountable to make sure that, again, we're using best practice. So for me, I think just going to session by session and just winging it, how can I be sure that what I'm doing is going to be effective for that client? There needs to be some sort of an idea or sense of what particular interventions I'm going to use because I know that they're evidence-based and I know that they're going to work for this particular presentation. So for me, having some sort of a plan in place helps protect me, but it also is really for the client, it's for the client's benefit.
Yeah, I agree. I think even Carl Rogers, he wasn't necessarily arguing that empathic listening and active listening, I think he was actually saying that that's not sufficient for change. Like, it's amazing. That was his argument. But I think even he acknowledged that it's not sufficient. And from what I'm hearing from you as well, it's that it's more than, I guess, our therapeutic approach. It's being accountable and making sure that you are practicing ethically and within your competence as well, but ensuring that the client gets what they need from therapy too.
Exactly. Yes, that's a great way to put it. And I think quite often what I find in my work with early career psychologists is when they get stuck in therapy, as we all do at times, and we hit roadblocks and we might feel like we don't know how to progress with a particular client, that often coming back to our case formulation and our treatment plan can be so helpful in just kind of uncovering, hold on, what's going on? Why am I stuck? Where am I stuck? And what do I need to do next? So for me, it's a really important part of the work that we do, and it's a really important skill for early career psychs to develop.
Yeah, I'd say it's foundational to being a psychologist.
Absolutely.
Yeah. Because literally, like when I go to supervision and it's like, okay, I'm stuck with this client, they say, go back to the formulation, let's have a look. It's so foundational.
It is foundational. And I think understandably, at times it can be overlooked when you're early in your career because you're so focused on even just the process and getting it right and trying to learn all these new things that you often forget the basics. And I'm not saying that this is basic, but, I suppose doing those case formulations and having a solid treatment plan, it's something that I've noticed as a supervisor is just so often overlooked because people are so focused on the other things and the other skills that they're trying to build. But I don't feel like we can be effective without it. It's essential.
Yeah, I'm just imagining an early career psych learning all these new techniques. And let's say they plan a session for thought disputation and evaluation. And they've got that all planned out, they've prepped, they've practiced, and then client comes in with something they want different. I think that can provoke a lot of anxiety in the psychologist because they're like, crap, I haven't prepared for this. I haven't spent 5 hours doing this. But it's really important, like you said earlier, to manage that spontaneity with the treatment plan as well. So then you're not invalidating your client and they're like, okay, I guess this is not important, this session. Guess we'll do what you want to do.
Absolutely. And I can't tell you how common I hear that from people. And just, again, as you said, it's very anxiety provoking when perhaps you plan for something, someone comes in, throws you a curveball, and you're like, oh dear, I hadn't planned for this. I don't have the worksheet available. And so I think for my supervisees, I often tell them that it's okay to have this loose plan. Actually, I recommend you do. But the way that you become flexible is that you're willing to adapt your plan with what your client brings you in that moment, in that session. And I'll typically do that. I have an idea that perhaps this session, for example, I'm working on teaching cognitive restructuring, and I'll work that into whatever it is that they bring me that day. So I'm kind of finding that balance between them and what they need and what they're bringing up, but also what I am already intending to do with them.
I love it when sessions go like that. I do it in a similar way, and clients will be like, oh, I'm sorry, this is irrelevant. And I'm like, no, this fits in perfectly. I can make this work with what we've got. So I might have wanted to talk about self-compassion. And then usually what's come up in their life, because you know the major themes from the formulation, you can usually work it into something that you are aware that this is a good direction that would be good to go in.
Absolutely.
Okay, I feel like hopefully listeners are convinced that it's a good thing to have a treatment plan. Do we want to go into this case study?
Let's do it.
Okay, so I just typed this out before the episode. So if I start saying a sentence that makes no sense, forgive me, listeners. Okay. Megan, this is a hypothetical case study, by the way, not based on anybody. Megan is a 24-year-old woman who completed a Bachelor of Commerce last year and started working full-time 1 month ago in customer service at a bank. Megan found it more difficult to learn the tasks at work than she had expected and began to have thoughts like, I'm stupid. When her colleagues began to invite her out for lunch, she felt like they were just being nice and actually didn't really like her. So subsequently, she's now withdrawn from all of her colleagues and eats lunch alone at her desk. Megan normally has an active social life where she catches up with friends and plays tennis, but these days she's so exhausted that she mostly watches TV in the evening, which causes her to feel a lot of guilt. She feels like she's letting everyone down and her mood has dropped quite a lot. And for relevant history for Megan, I've got Megan was bullied in high school for being at a higher weight, and consequently withdrew from social situations out of fear of judgment, preferring to have one close friend only. So she's very prone to self-criticism. Okay, Amanda, take it away.
Yes. Okay. And so I know you've got down there that the diagnosis is depression.
Correct.
So we are looking at some sort of a treatment plan then for depression. So how I usually start when I'm working with a client is the first thing I'm thinking about is what is the relevant diagnosis that I'm working with. So in this instance, of course, it's depression. And then I'm thinking about what are the evidence-based interventions for that. And so we know that first-line treatment for depression is CBT. So already I've kind of got my working model of this is what I'm going to be doing with this client, which informs not just my case formulation, but my treatment plan. Because, of course, every case formulation is going to be different depending on the therapeutic modality you're using. Every therapy has their own case formulation, depending on how they view psychological distress and how they view you would go about treating it.
Yeah, just speaking to that. So, for example, if we're formulating this from a cognitive behavioral standpoint, we would say that Megan's thoughts like, I'm stupid, are causing her to withdraw socially, and then that's producing further guilt, and then that's exacerbating the thoughts like, I'm stupid, nobody likes me, and that's causing a dip in her mood. So we've got the thoughts, feelings, behavior, interaction. But if I was to ask a schema therapist, they would say, it's Megan's defectiveness schema and she's in a helpless surrender mode and that's why she's disengaging. And if we ask an ACT therapist, they would say experiential avoidance is what's happening here. She's not living in line with her values and she is avoiding the negative emotion. So there's lots of different ways of doing it. And that's why I stumbled with my treatment planning episode that I recorded. And I was just like, oh crap, I made it so complicated already. But yeah, there are different ways of viewing distress, but we're going to make it super easy with the CBT, right?
Absolutely. This is why I love CBT. And
Yeah.
it's, I suppose, given that it's first line treatment for most things, but also it's so structured. So I think as an early career psych, this is the one I always tell my supervisees, get good at this first because it'll help you with most things. So I suppose taking the CBT approach, yes, you're right. The way that we're looking at somebody's distress is about trying to unpack those core beliefs, the automatic thoughts that are popping up, the emotions that that's causing, and then the subsequent behaviors that are exacerbating and maintaining that person's distress. So I usually like to do a 5P model. For me, that just, I don't know, I suppose it's ingrained into me, even from my kind of, early career days or when I was studying. So for me, even just as you were reading that, I was taking these mental notes going through the 5Ps. So I was thinking of things like, we already know the presenting problem is that she's having these symptoms of depression. The predisposing factor, we are thinking of the fact that she was bullied in high school. That's about as far as we know. So she was bullied in high school. This would have made her more vulnerable to developing the problem that she is having currently. We've got the precipitating factor, which is usually it's a discrete event or situation or incident that precedes the onset of symptoms. And so here we can see it was when she started the new job, and that she kind of started having these thoughts and feelings of self-doubt, given that she wasn't picking things up as well or as quickly as she would have expected. The perpetuating factors are I suppose it's the mechanism that keeps the problem going and probably the important thing or the very first place we're going to start in treatment. And so here, as you said, Bronwyn, we're thinking about it from a CBT model. So what's perpetuating it? It's not just her thoughts and those negative automatic thoughts that she's having. It's also her behaviors. So with depression, we are thinking of reduced activity levels, and having reduced activity levels, we know then that person does not have the opportunity to have that sense of pleasure and mastery, which is so important for your mood. So reduced levels of pleasure and mastery, of course, then reinforces and exacerbates a low mood. So I'd be already thinking of those things as my perpetuating factors, things I want to target, and then trying to look for those kind of nice protective factors that might tell me that she's going to hopefully do well in therapy.
Oh, crap. I did forget Megan's strengths. I always it's something that I do have in my formulation documents. I do have a template and I always make sure I have the strengths there because you can leave things out, and it's so important to have the protective factors as well as the client's strengths, because we don't want to almost fall into the trap that the client is facing, that perhaps they're inadequate or defective in some way. We want to say, look, you've got strengths that have helped you get this far, and we're going to incorporate that into our treatment so that we can work in a way that's most effective for you.
Absolutely. And I know that you don't have anything here, but I think that even just one thing I would think about is if she's here and she's shown up for therapy, that's a strength and that's a protective factor. She's obviously motivated to make some change, or she's hopefully engaged in the process.
Yeah, that's always a great protective factor. If you don't have anything else, it's always like, well, they haven't given up, like they're here in therapy and they're reaching out. So that's a huge strength of theirs.
Mm-hmm.
Yeah. Thank you for reminding us of that, Amanda. Could you just briefly tell us what are the 5Ps? What do they actually stand for, just so we can remind listeners?
Yeah. So you've got presenting, which is the presenting issue or presenting problem. You have predisposing, which is the vulnerabilities, what made someone vulnerable to developing the particular problem that is presenting. You have precipitating. Precipitating is it's usually a discrete incident or an event or maybe a build-up of a few things, or something that we can typically identify as the thing that triggered off the onset of current symptoms or the problem. Then you have perpetuating, which is the maintaining factors. So what are the current things that are happening in this client's life, or the things that they're even doing internally, externally, that are serving to maintain the problem? And protective factors are the things that would indicate that hopefully this client is going to be successful in treatment.
Brilliant. Thank you. And I do want to clarify for listeners as well that in cognitive behavioral therapy, my understanding is that we go by the maintaining factors, perpetuating factors. Those are the things we target in treatment. Is that right?
Absolutely. So that would be where I would start. So for me, it would be thinking about what the presenting problem is, looking at those perpetuating factors and knowing that that is where I'm going to start. But I'm probably also taking into account the predisposing factors, particularly as I move on and want to try and target core beliefs, maybe, a little bit later in therapy.
Yeah, because we want to prevent and reduce the risk of relapse in the future. And we know that targeting those core beliefs is a great way of achieving that.
Absolutely. I think it's taking it to that deeper level and making sure that we address, I suppose, the root cause of why they are perceiving their world as they are at the moment that is causing them distress.
Yeah, because with CBT, it's beliefs about yourself, other people in the world. And if we have a go at what Megan could be thinking, maybe she was bullied in high school, she said, for being at a higher weight. So she might have developed the belief that she was different, inadequate, somehow didn't measure up to her peers. And this might be leading into her current negative automatic thoughts of the workplace that I'm stupid, I don't measure up, they don't like me.
Yeah, absolutely.
Yeah.
That's probably a good example of a predisposing factor, as you said, something that's made her more vulnerable to now experiencing this problem.
Yeah. So I remember when I'm still an early career psych, but I remember the starting days, and I would get my 5 Ps or however many Ps I was using. There are so many Ps.
I love the Ps.
Yeah, Ps great. But I remember getting my Ps done and I was like, great job, Bronwyn. Yeah, give yourself the rest of the day off. You've done a great job. But then I would find it really hard to connect then with the treatment plan. I found it so difficult to go from that to, okay, what am I actually doing in sessions with the clients? Can you help us? How do we get from that to the what we're doing in sessions?
I think I'd be starting with, of course, the perpetuating factors that are maintaining the presenting problem, if we're thinking of the Ps. But I also find that there's this kind of rhythm to therapy. So I'm using that in conjunction with what I know maybe therapy should look like just overall. And so again, taking a CBT perspective, and we're looking at specifically depression in this instance, I know that the general rhythm is going to look like, I'd pass that maybe initial assessment and diagnosis stage, hopefully already incorporated some psychoeducation. So I've already got this idea that the first thing we're targeting is behavioral activation and their inactivity. And that is targeting one of their perpetuating factors. But I know that with depression, that's typically just the place you start. So inactivity first, I'd be looking at behavioral activation and those types of interventions before I then moved on to cognitive interventions and addressing some of those unhelpful automatic thoughts that she's having that is contributing to her distress, which would hopefully then lead me towards her core beliefs.
Do you explain the rationale for what you're doing to clients? I'm just curious. Are you we're going to start with your behavior for no reason at all?
I always explain to them what I'm doing and why, because I feel like it helps to engage them in the process. And I also want them I want them to have some insight into why I'm doing what I'm doing. I want them to have some sort of understanding, because I think for them, in my experience, it reinforces, I suppose, why I'm doing this, why it's going to be helpful to them, and gives them some incentive to actually engage in this activity. That I'm not just pulling this out of my backside, that actually what I'm choosing for you, this is based on science, this is how it works, this is why it works, and this is where we're going to begin. But typically, when I'm setting goals with my clients in therapy, I will always ask them for their objectives. What are your goals? What do you want to get out of this? I try not to be too directive in that instance. But once they kind of address their goals, for me, particularly if it's depression, I'll show them the way that we can meet those goals. And it typically always follows that rhythm of behavioral activation before we then move into cognitive interventions.
Yeah, so I'm just thinking for Megan, our hypothetical case, Megan used to play tennis and catch up with friends in the evening. So usually when clients come to us for therapy, when we ask them what they want to get out of therapy, it's some variation of, I want to feel better. And this is where I bring out my magic wand question. I love magic wand question. And sometimes it's miracle question, but I say, imagine that you've gone to bed and you've woken up tomorrow and a miracle has occurred and suddenly you're feeling better. What would you be doing differently? How would we know this miracle has occurred? And hopefully Megan would say to us, well, I'd be eating lunch with my colleagues and I'd be playing tennis. And then I'd seize on that and I'd be like, great, like that would be amazing, wouldn't it? And then I'd bring it back to my CBT triangle of thoughts, feelings, and behavior. And I'd say to Megan, so Megan, if you got back into playing tennis just for 10 minutes, you just went to the court and just like hit around a ball for a bit, how do you think you'd be feeling? No, I'd be feeling a bit more active, maybe like a bit, bit energy draining to start off with because you haven't been doing tennis much lately. But how would you be thinking about yourself? You'd be like, oh, it's good that I got myself to do that. So that's immediately providing a rationale for why it's good to start with behavioral activation.
For me, I try and also provide just that little bit of science behind it about how, our sense of pleasure and mastery is linked to our mood. And understandably, when you're depressed, you would naturally not have much motivation, have low energy levels, have low mood. Therefore, you don't really have the incentive or drive to do things. And that then means that I don't have the opportunity to feel pleasure and mastery. We need to be doing things to get pleasure and mastery. And so I kind of explain to my clients like that and say that understandably, because of the way you're feeling, you haven't been doing as much or you haven't been engaging in the activities that used to bring you that sense of pleasure and achievement. And here's why it's important. And here's why this is part of our plan. We're going to be looking at trying to increase some of those meaningful activities so you can have an opportunity to feel pleasure and mastery again, which will then flow on into improving your mood.
I love that science-based explanation because often with depression, the clients are experiencing low mood. They might also be experiencing hopelessness, like this isn't going to get better. And so having that science-backed explanation can also help clients know that, look, we know what helps people generally feel pretty good, and it's by engaging in pleasurable activities where they feel a sense of mastery and achievement. And with depression, I do empathize with clients, and I'm like, I usually say to clients actually that depression, and this is true, it's my least liked mental illness because it's such a bitch to recover from because you have to do things before you feel better, and that sucks.
It sucks.
Yeah.
And, I speak about this so often. Just the fact that I think we're given this false impression at university that depression is like, oh, it's the bread and butter.
Yeah, it's easy breezy.
That's the simple stuff.
Yeah.
Whereas for me, I'm like, give me the anxiety disorders any day. That's the simple stuff. Whereas, I feel like someone with depression, it's so uniquely challenging. And I think for the reason you just said, it's like that they're going through these whole host of symptoms that are crippling them, that are stopping them from being able to move forward and do the things that will help them get better. And it is so uniquely challenging to work with a depressed client. And I think many early career psychs are typically, in my experience, are shocked by that like, I thought this was meant to be easy. Yeah. This was meant to be the easy stuff. It's like, no, this actually is the hard work because, again, yes, these clients are facing all these barriers and you're trying to help them move through that. As you said, you have to start doing things before you feel better. And to tell someone with depression that, it's really hard for them to digest.
It is. It's like, tough Bicky, sorry. Like, this is the way it is. Like, trust me, trust the therapist. So you also have to build that trust in sessions as well for them to believe that science-backed explanation. It's really quite complicated. I know how we just think it's so easy with depression, but I know maybe because we know really what works to help it. Amanda, I was interested to know, because you just rattled off what we'd do for depression. We'd do behavioural activation, then we would go to some of the cognitive interventions, then we might go to core beliefs. How do we know, where would an early career psych go to know what the treatment plan is for depression?
I got a few recommendations. If you're looking at CBT specifically, probably one of the better textbooks I've read on this topic would be CBT Basics and Beyond, and that's by Judith Beck.
That's a brilliant book.
I think it's it's very practical. I love how there's just lots of examples of the sessions, and I think it wasn't dry to read either. I feel like I could read it quite easily, very digestible, very easy to take that and then implement things. I also actually recently released, just a few months ago, a manual. And this was geared towards early career psychs or psychologists who maybe just don't have a lot of experience with maybe working with depression in a clinical setting. And that manual is called Treating Depression, a manual for therapists. And what I've done, because I love a lot of structure, is I've created a complete session-by-session guide for you. And using CBT, that is the focus, but I've created session plans, lots of worksheets and handouts to give your clients, and essentially a complete roadmap from the beginning, the very first session, all the way to the end of therapy, of what it looks like, what to do, step by step.
That's brilliant. I'm so glad we have you because when you said like it's so structured, I was like, because I love structure too, but I don't think I'm unique in this. I reckon early career psychs, like we crave structure. I know as an early career psych, I would hate it when my supervisor was like, oh, you just like talk and listen. And I'd be like, tell me what to do.
Exactly. I was the same. So I feel like for me, that's where this kind of grew from. Like the fact that I knew when I was early on that this is exactly what I would have wanted. Just somebody tell me what to do. Give me a session by session playbook of what I'm meant to be doing in session. And so this is kind of, I suppose, why I developed it as just that guide for people, particularly for working with depression. But I know that it would be most valuable for early career psychs.
Brilliant. So listeners, what Amanda has done is taken the research literature and translated it into easy digestible bites that we can use in sessions with clients. Is that right, Amanda?
Absolutely. Yes.
That's fantastic.
So thank you. I even test ran it on a group of early career psychologists before I kind of hit publish, just to make sure I got everyone's feedback and it was going to be something that was as valuable as possible for those that I intend to use it for. So hopefully you will find it useful.
Yeah, and I will link to that in the show notes, listeners, and I hope that it's very helpful for you as well. So one thing with that is I absolutely would have found it helpful as an early career psych. I literally remember emailing my colleagues very soon into my placement. Like most people, I was thrown in the deep end, wasn't told how to do anything, wasn't taught anything. So I'm emailing my colleagues being like, what do you do when you treat depression? Give me a 6-session plan outline. And then they, write down, here's depression, behavioral activation, thought records, etc. Here's anxiety, relaxation, thoughts records, exposure, that kind of stuff. And I was like, okay, that's all I had to go on. So, so your stuff is brilliant.
Thanks, Bronwyn.
Yeah. So in Megan, let's just return to Megan, a hypothetical case of Megan. So we've got here that we'd probably start out behavioral activation. So we'd be encouraging her to connect socially, to pick up tennis again, do that consistently, and then we would go to perhaps evaluating her thoughts.
So typically I'd wait for some symptom reduction by using behavioral activation, and then I would move towards the cognitive intervention. So I find that usually for a lot of clients with straightforward depression that don't have comorbid psychological issues, that typically you'll see some improvement in a few weeks if they're doing behavioral activation consistently. And so I always get my clients to aim for at least one activity every day that would give them an opportunity to feel pleasure, and one activity every day that would give them an opportunity to feel mastery. And they can be very simple things. They don't have to be things that they're spending hours doing, but the point is that they're looking at increasing those two things every single day.
Yeah, I often say to clients with depression, it's the effort, not the outcome. So I don't care like if you mow the lawn for 10 minutes and it looks like rubbish and the lawnmower didn't work. I don't care. The point is that you went out and you did it. And then I often pair that with giving themselves credit. So this is something directly I picked up from Judith Beck. And she's like, you need to tell clients like, you don't have to throw yourself a big celebration, but you do need to say to yourself, it's good I got myself to do that.
Yes, I think it's really important because, again, particularly with clients with depression who have this sense of, I suppose, this negative perception of self, that giving themselves credit for doing things and recognizing how actually hard it is when you have depression to be doing these things can help build their sense of, I suppose, a sense of self-esteem, a sense of
really
self-worth.
Does. And yeah, it's reinforcing and proves their self-worth. It's like, yeah, I did that. So it's a cognitive intervention as well. So we know that with the CBT model, behavior influences our thinking. And that's why we start with it a large part as well, because we know that if we get them to do things, we don't actually have to target the thoughts directly. They can naturally change.
Yeah, that's so true. I think that, what you'll find is that if you were to try and start with cognitive interventions first, it would almost be too challenging with someone who is depressed.
Yeah.
I think the goal is really about just getting them moving, getting them to start feeling that sense of motivation and sense of self-worth and achievement and pleasure again. And you will find that naturally that does filter into having reduced negative automatic thoughts. It won't go away completely.
No.
We do need to tackle them, but it does flow into their thoughts. You're right.
It's so easy. It makes it easy when you get to the cognitive interventions as well, because then you've got things from their life directly to pick up on. So, for example, if you're examining the thought, I'm stupid and worthless, you can point out to them, hey, remember last week when you took a letter to the post office? I don't know what people do these days. I haven't done that for a long time. But, you've got things to tap into. And so it's a really good way to draw from, so that you're not starting with zero and they're like, no, I got nothing. And you're like, no, you told me 5 things last week.
Exactly. I think as well, it's like, I think a big thing is the motivation piece too, right? So, of course, some of the complexity of working with depression is the fact that they have low motivation. So hopefully, and what you'll find is, and what we're trying to teach our clients is, you get the motivation in the doing. You will not get it before you start doing things, not if you have depression anyway. So you get the motivation in the doing. And so the more that we can get them doing, the more motivation hopefully will flow on from that, which will also make just the process and engagement in therapy so much easier.
Yeah, absolutely. I used to work with older adults, and what I would say to them is, the more you do, the more you do, the less you do, the less you do. And that was my mantra to them. And I think they got really sick of me, but they really understood it. And then my other one was up and out. So this was get out of bed, get out. And it really just needed to be simple so that they would remember it. And sometimes they'd walk in and they'd look at me and they're like, the more you do, the more you do. And I was like, I see you teasing me, but it works.
It does.
Yeah.
It does.
Yeah. So we've got the cognitive interventions, and typically in CBT, this is doing some variation of a thought record, and then the A, B, C, D, E, F. I think we're up to F. I don't know if we're up to E. Maybe we're not up to F. I can't remember. Is there an F?
An F? Maybe I've lost sight of what we're talking about.
So the antecedents, behavior, cognition. What's the D? Detective work. E, evaluation.
Oh, wow. I do it completely differently.
Oh, really? What do you do?
Yeah. So I think for me, and hopefully we're on the same page as we're talking about this bit, when I do the cognitive work, I will start with, the first process for me is starting to help them to actually identify the thoughts. I find a lot of clients are stuck there. They don't even know the thoughts that are connected to their distress. So the first part is always about being able to notice, being able to identify the thoughts that are causing the distress. Then I introduce the concept of cognitive distortions or thinking errors, and just try and help them see those in relation to the context that are happening in their lives and get familiar with those. Once we've done some of that work and then being able to pick up the thoughts they're having and putting them in context of potentially one of these thinking errors, I then move on to helping them learn how to evaluate their thinking using Socratic style techniques before we go on to modification.
Yeah, we're talking about the same thing. We're just like,
are we?
Yeah, we are. We must. But this is really good because it highlights like how you can learn things in such different ways.
Yeah. I never heard of A, B, C, D, E, F.
Yeah, I don't think there is an F. I think I made that up. But yeah, definitely that's how I learned it and connecting it. But yeah, using the Socratic questioning, getting the thought distortions. Sometimes I do it like I give them the metaphor as like you're in a courtroom and you're trying to convince the judge that here's the evidence of why the defendant is stupid and like worthless, and here's the evidence like, no, Your Honor, they're not stupid and worthless. And then I kind of do it that way. Pro tip, it doesn't work if your client is a lawyer and then they get really anxious about courtroom interactions. I've done that before. So, Amanda, we've talked briefly about the interventions we would use with Megan, our hypothetical case, who's experiencing depression, the types of interventions that we might use. We've gotten this from your resource book, but also from textbooks. And listeners, for any other mental health condition that you see in your clients, grab a textbook out. There are treatment plans. They are abundant. They are out there. If you're not sure, ask your supervisor, what's the best textbook to look at for a treatment plan for this condition? And I can guarantee there will be a session-by-session plan out there. One of my favorite textbooks, and I don't know how to pronounce the name, but the author's name is Leahy, which is Leahy. Lots of treatment plans there. I'll link it in the show notes as well. But Amanda, what do we do to wrap up treatment?
So typically I like to start by tapering off sessions. And so this is once I've noticed, and the client has, of course, noticed too, that their symptoms are improving, they're getting better. I would start by just spacing out sessions to increase their own sense of competence in managing their symptoms and managing their problems, and just checking in to see, what happens when we don't see each other for 3 weeks or 4 weeks. How are they managing in between sessions? And ideally what I'm looking for is not that all their problems have gone away and that there's no issues whatsoever, but really that they were able to manage that independently and felt confident about doing so, and were able to, I suppose, have those lengthier periods of time between sessions without having a complete, relapse of symptoms. And so I do that for a few sessions, and I'd keep gradually tapering things out longer and longer. And then I typically like to wrap up once me and the client have agreed that, okay, we've done the work we can do here. You've obviously met the objectives of treatment, you've improved, etc. And I always like to wrap things up with a final session where we would do like a relapse prevention type protocol.
Yeah, same. Yeah. And I guess recognizing that progress, but also being like, look, it's not uncommon for this stuff to come back. And if it does come back, what are we going to do to help you maintain the progress and gains that you have made?
Yeah, I think it's so important. And I think that understandably clients, will sometimes get better and then just kind of drop out, before you get a chance to do a session like that. But I think it's really important because it helps consolidate, I suppose, all the skills that they've learned, and the progress that they've made, as you said, and just really being able to reflect on, okay, what's worked, what didn't work, what's helped me get to where I am, and what do I need to keep doing to maintain this, knowing that our mental health is something that, of course, we need to tend to, just like our physical health, that, it's not something that once we've reached a goal and now, okay, fantastic, we're doing psychologically well or better, that it just stops there. We need to keep doing things to maintain that. And so for me, going through that with my client, reviewing those key things and key skills that we've gone over in therapy, and also just devising that plan of what do we do, as you said, if things are to start maybe going backwards. And if I start to notice a reemergence of symptoms. And this is where I would recommend firstly for them to attempt to self-manage and maybe have what I would call like a self-therapy session where they would revisit some of the skills and techniques from therapy, try and implement it themselves. If they find that is not effective and they're not able to overcome their issues by doing that, of course, my door's open. Reach back out and you can re-engage.
Perfect. And that fits in within the CBT framework as well. And I'm aware that I've got a worksheet from Judith Beck that sets up self-therapy sessions as well. So it's very consistent with that CBT framework. And we find that this is generally quite effective for patients. And I mean, disclaimer, it's like bearing in mind that you get your formulation correct as well.
Yeah, definitely. And I think that's why it's so important, isn't it? How we start therapy, making sure that our case formulation is thorough, making sure we've got a good solid treatment plan, which follows from our case formulation, I think really helps us
do good.
Do good.
It really helps treatment flow smoothly, and it helps the client get what they need from therapy.
Yeah, which is, of course, the main point, really, of the welfare of the client.
Amanda, I wanted to move on if we could. I think that was really helpful going through this case study of Megan, a hypothetical case study, and hopefully listeners are a bit more reassured or a bit more knowledgeable about what to do with the treatment planning and the formulation. But I just wanted to hear from you, maybe like what we do if we encounter some roadblocks in treatment planning.
So I think I like to try and pre-plan for roadblocks. I mean, there's only so much you can pre-plan for a roadblock, but have some sort of a sense when I meet a client of some of the things that might come up that would get in the way. And usually I discuss this with my client in those early sessions of what they might perceive will get in the way of even just doing a particular intervention and trying to help them problem solve around that. And so usually that comes into my case formulation and my treatment plan. But what I tend to find is where there are roadblocks in therapy, the most useful first thing or first step that you can do is revising your case formulation and your treatment plan. It's just coming back to that and saying, okay, where am I at? Do I need to update this now that I've got more information about my client? Let's go back and do another case formulation, see where I am, and then try and tailor and target my therapy accordingly.
No, that's really helpful with anticipating those roadblocks, but also discussing them openly with the client.
Yeah, I think that clients are usually quite insightful and well aware of the things that they know are going to come up and probably stop them from, say, doing that behavioral activation strategy this week or from sitting down and doing thought logs in between sessions. And clients are quite insightful as to the things that will probably stop them and get in the way of them being able to be productive in between sessions. So I always engage them in that process of chatting about roadblocks so that we can problem solve together and hopefully try and minimize any roadblocks.
Yeah, the way I do it with clients is I'm like, okay, scale 1 to 10, how likely are you to play tennis for 10 minutes? That'll be a solid 4, Bronwyn. Probably not. Okay, how come not a 3? Oh, because I really want to do tennis. How could we get that up to a 7 or 8? I could set a reminder on my phone. And that's the kind of problem solving. Is that what you do?
I see what you're doing there, a bit of motivational interviewing.
Yeah, sure am.
I think for me, and I love that strategy, I think for me, typically, I would try and, particularly for someone with depression, I would just try and break it down and make whatever it is I want them to do as simple as possible for them, keeping in mind how challenging it is to have depression, not having the energy, motivation, having low mood, all of the symptoms that actually are debilitating that person. So I keep that in mind. And if I think about a roadblock, like let's say one of our goals was for them to do 30 minutes of exercise or go for a walk, and they were unable to do that, we would talk through all the things that got in the way. Maybe they were too tired. Maybe, I don't know, something else popped up on that day and they just didn't have the time. And we would then sit down together and maybe work out, how are we going to set you up for success? So does that mean we need to pick a very specific time of day we know that you're most likely to do it?
Great idea.
And that could look like the morning for that person. And how are we going to make sure you then do it in the morning? Do you need to go to sleep with your gym clothes on? Or what are we going to do to set you up for success and make sure that you can actually reach that goal? And so that's typically what I would be doing. It's more of that problem-solving stuff and trying to find ways to navigate it with that person, making sure I'm keeping in mind their level of functioning and capacity, and not underestimating how hard these things are for my clients.
Yeah, absolutely. I've had sometimes with patients, with people who are not functioning very well, the behavioral activation can be, I want you to brush your teeth today. Yeah, I want you to get up and make your bed. It really is tailoring it to the person in front of you.
Yeah, I think it's so important. And again, coming back to what we were saying earlier about how uniquely challenging it is working with depression, and how when you are early career, you may underestimate just how hard it is, not just for you as the clinician, but for that person living it, and how hard these little things are for them to do that we think might be trivial, but to them feel like these monumental tasks.
Yeah, it's a great way to, I guess, experience sometimes frustration as an early career psychologist, because you might have expected that your client would get better, and sometimes that can produce feelings of self-doubt in the therapist, like, why aren't they getting better? Maybe it's something to do with me, or it might produce frustration. So it's also a really great opportunity to reflect on your own reactions.
I think so too, and I've definitely come across that with some early career psychs. Maybe, as you said, that sense of frustration of why are they not doing the homework? Why are they not progressing? Why aren't they getting better? I'm doing all the right things. And so, yes, you're right. I think often maybe needing to reflect on ourselves, our own expectations of treatment, and even just our expectations of our clients and what they can manage at this point in their lives.
Definitely. Amanda, are there any other roadblocks in treatment planning that you wanted to get across to listeners?
I think the only other thing I would say is just thinking back to that idea about over planning and under planning, and really trying to find a balance with your treatment planning. I've definitely seen both extremes. I've seen clinicians or psychologists that go in and maybe just wing it and see what happens this session, and we'll just go with it. And I've seen psychologists who have very detailed plans. Maybe they've got a play-by-play of every little thing that they will do in that one session with the client, and perhaps over-planning. And so I would say to you that it's tricky when you're learning the ropes, but finding the balance is key. You don't want to not have a plan. You want to have a plan, but you don't want to over-plan to the point that you are stressing yourself and putting undue pressure on yourself, but also putting undue pressure on the process of therapy and what you can realistically achieve inside of a session. And so for me, and I know that, I say this obviously later on in my career, so I don't take it lightly that you're still learning the ropes, but for me, I've just got this really broad roadmap in my head of, again, how therapy should look like if I'm working with someone with depression or, say, social phobia or something as such. And, for example, depression, I know that I'm going to be starting with behavioral activation, then I go to cognitive stuff, then I'll go to the core beliefs. But then I'll have a bit of a loose plan for every session too. And it will usually follow on, hopefully logically, from what we've covered in the last session. So if I'm doing behavioral activation today, I'll know that next session we're going to be following probably with that. And maybe then the session after I'm doing, thinking errors, and then that will follow on to evaluating thoughts. And so I've always got these loose ideas, and I typically go by the rule that I want to teach my client at least one thing every session. I want to focus on one skill, and I try not to put too much pressure beyond that, because I want to allow room for the client to bring what they need. But I always have at least one objective for every session, and hopefully it builds off the last session. We are building up to something greater.
Over-preparing can really take away the spontaneity, as we were talking about earlier, but it can also prevent clients from bringing what's important for them to sessions, but it can also cause us to feel really stressed. So it sounds like there's, I guess, an optimal point for preparing for each of us. Don't go just wing it territory, but similarly don't over-prepare for like 4 hours or write everything out.
Yeah, exactly. And I know it's hard to kind of clarify what that balance is when you're early on. And I know that naturally when you are early on in your career and you're learning the ropes, you will be planning a little bit more than, say, I might be. But I would still tell you that again, have a loose plan for the session, have a broader plan overall for your treatment, allow some flexibility, make sure that there's some room there for that spontaneity, for your client to bring what they need and for you to adapt accordingly. And just know that in general, your therapy will start to follow this nice rhythm. And soon enough, the more you practice and the more skilled you get, you'll find your rhythm of therapy, and you'll start kind of learning, I suppose, the dance of therapy, if you want to call it.
Yeah, we'll call it a dance. Why not?
We'll call it a dance. You'll start to learn, I suppose, how it should look and how it should feel, and where you need to tighten things up and where you might need to be a bit more flexible. And again, just not putting too much pressure on yourselves, on your clients, or on the process for things to go faster than they need to.
I hear that very deeply. I used to over-prepare so much, and some of it was helpful, like actually going in depth through exercises. And so perhaps for early career psychs, judge for yourself, like, is this helpful, but is this past the point where it is helpful, and is it stressing me out? Is it putting too much pressure on the clients? I remember something I had to work on quite early is that I used to give clients too much homework to do. So I'd be giving them like 4 or 5 things to do, and I knew that I would be overwhelming them, but it was purely to appease my own anxiety. And so I had to train myself to make sure like you get one thing, not like 4 or 5 things, even though I'm excited to tell you 5 billion things, because that's in recognition of what the client can benefit from.
Yeah, I totally get that. And I think, I myself would have struggled with that as an early career psych too, and just that performance anxiety you get. And I think it comes from a good place. I mean, we're all in this hopefully because we want to help and we want to do good and we want to help these clients that are sitting in front of us. So I think that, we put this kind of undue amount of pressure and expectations on ourselves in the process. And it's because we just want to help our clients. We want them to get better, so it's coming from this really good place. But again, I think that ultimately having that level of pressure and expectation doesn't end up being very helpful, and I think that therapy can quite often be a slow process. We don't get the same kinds of rewards immediately and often that you might in other professions. And so you don't always have that feedback to tell you I'm doing well or I'm doing this right. And so naturally it can lead you to feel quite anxious when you are early on. Questions like, am I doing this right? Am I doing it well? Am I doing enough? Am I doing enough for this client? And so that might lead to over-preparing and over-planning.
Yes. Amanda, I think this has been a great discussion. I'm so glad that we could get to the discussion on finding that balance between under and over-planning, as well as planning for roadblocks in treatment. So I just wanted to ask you, Amanda, if listeners want to find out more about you or get in contact or take advantage of some of your resources, where can they find you?
So you can find me on my website, www.amandamosespsychology.com.au. I'm also quite active on my LinkedIn page, which is Amanda Moses, and my Facebook page as well. So you can find me on any of those, and I'm always happy to chat. Very much always welcome people to reach out and say hi.
Fantastic. Well, thank you so much, Amanda, for coming on the podcast and sharing your expertise with us. It was truly a pleasure, and I'm so glad that we could benefit. This was a fun chat.
It was so much fun. Thank you so much for having me.
Lovely. Well, thanks so much, listeners, for listening as well. Take care and catch you next time. Bye.